What if the reason you can't afford your medication isn't an accident? What if the system was designed that way? From the creators of the Modern Medical Mafia Docuseries, this is the podcast that goes deeper, unfiltered, uncut, and impossible to ignore. Behind every prescription is a story, a negotiation, a decision made in a boardroom. That could mean life or death. In this series, you'll hear the full conversations, the voices of patients, doctors, pharmacists, lawmakers, and insiders pulling back the curtain on pharmacy benefit managers, the middlemen accused of quietly controlling the cost of survival in America. This isn't just about healthcare. It's about power. It's about profit. And it's about who pays the price. This is the Modern Medical Mafia podcast. And this is the full story. Dan Strause is a Wisconsin-based leader, former CPA, auditor at Arthur Andersen, then a Big Six national accounting firm, entrepreneur, and co-founder of Hometown Pharmacy, a network of independent pharmacies focused on community-centered care. Over the years, he has become a vocal advocate for independent pharmacies and a critic of pharmacy benefit manager practices. He is also involved in broader efforts to raise awareness about drug pricing and access, including his work on the Modern Medical Mafia Docuseries, and his putting his heart and soul into helping educate, enrage, and engage the American public to understand what is truly going on regarding the healthcare system. He was asked to perform auditor work for patients and employers around healthcare-related issues. He shares his work in the upcoming podcasts on the Patient Advocate Auditor, and now listen to his story on the Modern Medical Mafia podcast.
My name is Dan Strause. I'm a little bit of an odd duck, and maybe the person that's main job is to translate complexity into Main Street. I started my career as an accountant for a Big Six accounting firm, and I only bring that up because every 3 weeks we went to a different type of job, and with that you knew absolutely nothing about that industry, and you learned to ask smart people questions. And at the end of 3 weeks you became intelligent subject because you asked questions. And when it comes to healthcare and PBMs, etc., it takes a lot of questions, and we're also trained in healthy skepticism. Trust but verify. And what you'll find out later when it comes to healthcare, there's a lot of trusting on false assumptions that nobody verifies, and based on those assumptions, people are fooled into a lot of serious items that they use as an assumption, turns out not to be true, and harms an awful lot of people. After Arthur Andersen, I had the blessing of working for some multinational companies in some different positions. And then I had a good friend about 22 years ago that stated that he wanted to be able to buy 5 pharmacies. And looked into it, and pharmacy is a very odd business, as we'll find out later. But we went in with a very core mission of pharmacists, you take care of patients and get patient outcomes. I'll take care of you to make sure we're solid. We were very much pragmatic, right? We are your typical Main Street, rural type of farm community strong. We do a lot of things ourselves. Turns out folks liked our style. So we went from 5 stores to 7 to 12 to 17, and we ended up to 70 pharmacies. And we had our own health plan. And our own health plan, we had the same issues that everybody else did. That our premiums were going up 15, 20% every year. We'd look into it and says, well, that's just the way it is. And you couldn't afford that. So what would you do is you would raise co-pays, lower benefits, and that same song and dance for too many years. And then we have the 1 year where we supposedly had a good year where we didn't spend as much. And they said, well, you're still going to get a premium increase. I thought something is absolutely wrong. So in our own health insurance plan, we started digging deep. And then that's where we started finding a lot of issues that we'll get into later. And then when you're a pharmacy on Main Street, you get to meet an awful lot of people. I'm very, very proud of our pharmacists because we have a reputation of really taking care of people. And with that, people tell us what's happening to them. And it's absolutely soul-crushing and mind-numbing, the things you see and says, this just cannot be right. So the first time you hear something, you says, well, that must be a one-off. Then you hear it again and again and says, no, we got a problem here. We need to start asking questions. And then you look around the country, ask questions. No, this is actually worse than I thought. And this whole mission of this docuseries has been an explosion of that, where we think there's 10 things wrong. It's really 20, right? So it is complex, but the nice thing is when you ask enough questions and you trust and verify, now you can find a way to take complex situations and break it down so we can explain it to our family and friends on Main Street in the big town of Rye, Wisconsin, a population of 1,100.
Well, I think bringing up the example of being a pharmacy and spending however much money on pharmaceuticals out of that benefit plan, I think that's a good example to bring up just to show, and then going into self-insurance.
There's a couple of very personal experiences that I think a lot of folks can relate to. First, I'm going to talk about on the patient side, then two as an employer with a health plan. So the first one, we have a wonderful aunt that all of us dearly loved. And she used to come in the pharmacy, and she was on a generic medication where her copay was $10. And she would come in the first of the month with $20. She'd buy her medicine, but then also buy $10 worth of candies and goodies. And on her way home, she would stop and visit 10 different folks to just spread a little love and a piece of candy. One January, she comes in, and her insurance company said, you no longer can get that generic medication for $10 that you've been on for the longest time. Now you have to take a brand, and it's going to cost you $75. She still only had $20. So now she's in tears. We see that. There's no way we're going to let her leave without her medicine. But there's where it's like, this is wrong. How can a good generic that did the job well for so many years all of a sudden not be good enough? And you realize it's a form of extortion. When people are forced to pay more for the price of drugs, this is healthcare. This is just wrong. So that left a deep scar, like something's wrong there, and created an awful lot of questions. Then secondly, our own health plan, right? And I had to fight for almost a year with our health insurance company to say, I'd like to know my spend on pharmacy. This is our own medicines coming off our own shelves, given to our own people. Well, we can't share that with you because of HIPAA. No, I don't want individuals' names. There's nothing about HIPAA. I know how much came off our shelves in dollars, how much that cost our own health plan. And I almost had to threaten a lawsuit, and finally I got it, and I realized why they kept it a secret. $60,000 of medicines came off our own shelves and went into our own people's hands, and our health plan charged us $360,000. Now, that is just wrong on so many levels, and that was an eye-opening moment. If they're doing it to us, what are they doing to everybody else? And we realized we just came upon a nugget of information that most folks never have privy to. They aren't marking up 10%. They aren't marking up 6%. They're marking up 500%. Who's benefiting? Them. That's like a skim off the top. Them are health plans and PBMs. PBMs start out in the late 60s and 70s to simply be a paper pusher. The simplest form to say it is when health plans start covering prescription medicines. Let's say company X and company Y each said, well, there's 100 pharmacies in my network. I don't want to write 100 checks, right? And the pharmacies themselves says, well, I don't want to get 100 checks from 100 different companies. So PBMs were simply in the middle to say, okay, company X, write me your entire check. And so will 20 other companies, then I'll take that and then I'll write the checks to the pharmacies. Well, that works. It was great for the employer or the third-party administrator for the employer. And pharmacies, we liked that to begin with because it made life simpler. That's why they existed for so long. And why nobody ever heard of them, because whoever hears about the paper pusher that's doing this. Well, as we'll find out when we talk about history, they went from a paper pusher that had no regulation into the most powerful folks that impact the cost of medicines and now are literally extorting people because they have the benefit of not being understood or known. In our journey, we find that if you talk to 100 people on Main Street, often less than one has ever even heard of a PBM, much less know what they actually do. Everybody knows there's a problem. Who's the bad guy? How did we get here? Where did they come from? How did they get away with it? We hear that all and all again, and that was the inspiration of making this docuseries, is we had to explain who's doing it, how do we fix it, right? And how did we get here? So this whole docuseries is actually meant to solve that core, which we probably can do in literally 5 minutes. But the question is, will you believe us? So what I'm so proud of is the number of highly qualified, highly intelligent people that know intimate details that want to share that with the audience so they know this is truth. In healthcare, we all want to believe that's the one area of our country and you just want to trust, right? There's inherent trust. And I want to make sure we're very, very emphatic here. Doctors, nurses, pharmacists, they're amazing people. They get into healthcare for the right reasons. They're in to take care of the patients. The unfortunate thing is many of them are forced to work for organizations that people will never meet, make the rules, make the decisions, and up at the C-suite level, we call it, that's the CEOs and CFOs, board of directors, whose responsibility is to their shareholders, that their job is to make money for their shareholders. And so the way the game has been, I won't say rigged, because as we'll go into it, a couple great pieces of federal legislation that was well intended had loopholes. Those loopholes allowed for very savvy business folks to exploit and operate under the radar and unfortunately hurt the rest of us.
And so with that, in in layman's terms, can you walk us through the timeline of the development of PBMs to get us to where we are today, to how they've taken advantage of the system and created this monstrosity of a mafia?
Absolutely. So as we mentioned, the very onset, they were paper pushers. Hey, collect a check, write a check. Then at sometime in the near future, they said, you know what? We run a company. We run a tire company. We run gas stations. We even if we run a hospital or we run a manufacturing plant, we are great at our business. What do we know about healthcare and what do we know about prescription medicines? Brand, generic, what works, what doesn't? How do we do that? Well, pharmacists are trained. That's their incredible journey is they learn a great amount of biochemistry. So if you're someone to trust saying, okay, should I take this medicine or that medicine? Doctors are amazing. They find an issue and they diagnose. And it used to be for the longest time, diagnosis, now go to the pharmacist and they prescribe. That changed about 20 years ago for various reasons. But at the end of the day, pharmacists have in-depth knowledge of pharmaceuticals. Makes sense, right? So somebody had the great idea, and at first it made sense. Got to make a formulary. What's a formulary? A formulary is a health plan. These are the drugs you're going to cover. Well, how do you make that decision, right? Again, if you're running a trucking company, how do you know what medicines to cover? Well, that's why the pharmacy benefit manager early said, we'll set the formulary for you. Because like many countries do initially, here is the diagnosis, here is the mechanism of action, and all the different things that I know just enough about to be dangerous, but I'm not a pharmacist, but I've listened to smart folks say, here is a combination of the science and the efficacy and the cost to make a really prudent decision that this is the medicine that we should be on. And initially, that makes perfect sense. I would want a pharmacist to do that for me, right? So again, every part of the logic tree, you're saying that makes sense. Well, where did it go wrong? Well, 2003 was a very, very significant year. Because up until that time, not only did PBMs that do the formulary, but then folks would say, well, geez, if you're doing your formulary management for 10 companies, boy, if you bought together, can we get a better deal? Yeah, if you buy 100,000 bottles versus 100 bottles, you should get a better deal. And the intent was for that to go to the company, right? Or to the patient, right? Well, unfortunately, the PBMs kind of said, well, yeah, I can get this discount, but do I have to share it all? But there was fair competition, and there was enough around that let's call the malfeasance or that usury to be not as big of an issue as it certainly is today. So 2003, what happened then? Well, a very, very good federal legislation called Medicare D, right? So absolutely believe in the intent of Medicare D, which was if you make prescription medicines more affordable for the elderly, can you then help prevent more hospitalizations and other big cost events? In other words, keep them healthier so they don't go to the hospital or fall down in an ambulance. Makes perfect sense. Well, at that time, they call legislative capture, which is a fancy way of saying lobbyist, came in, and the lobbyists between pharma and PBM said, hey, federal government, you're about to become the largest purchaser of prescription medicines in the world. That's a pretty big stick. Let us maximize that for you. Again, that makes perfect sense. Well, how are we going to do that? Well, to do that, we need to get a get-out-of-jail-free card. What do you mean by that? Well, there's a whole bunch of laws in the books that prevent kickbacks for anything the federal government is spending, right? You can't play games. Well, guess what? There was a special exemption given to pharma and PBMs for Medicare D that allowed pharma and PBMs to basically do the most elaborate kickback scheme in world history. And we'll find out later, if the FTC later verifying it, is created this black box, proprietary information. As we'll see later, that we have a data guru that right now, last year there's $330 billion unaccounted for. Where'd it go? Well, it doesn't take long. You can look on Wall Street and folks' earnings and profitability and see exactly where it went to, but of course they have to hide it. So 2003 was huge because it created the ability for there to be kickback games and non-transparent kickback games. So why didn't this go terrible in 2003? Like everything else, is like, this is kind of a newfound toy. What can we get away with, in essence? And so then you get just a small handful of PBMs that get this big advantage, which allows them to be more profitable and buy up their competition to the point where now you have 3 large PBMs owning over 80% of the market. I think all of us know that if you have 3 entities that get to control 80% of the market, that's an incredible amount of power. And like all power, is that used for the benefit of the greater good, or used for the ability to be able to make incredibly obscene amounts of money at the expense and detriment of others? Now there's so much overwhelming evidence that it's the latter. There are people literally dying because they can't afford their medicines. There are people literally going bankrupt because they can't afford their medicines. We've been almost conditioned as a country, well, that's just the way it is. But we've never asked the question, well, how much does it cost to make? Now, how angry are people when they realize the cost to make a drug is $16, but they're getting charged $7,000? There's one thing that's charged fair. If you want to purchase a car, you get to spend whatever you want to spend for as much luxury or convenience as you want. But when it comes to medicines, like, this isn't about luxury. This is about potentially life and death. That should not be an area we get extorted. It's not an area we should be manipulated or blindsided or black boxed. Well, that's happening, unfortunately, to a great extent. So 2003, pharma and PBMs get this incredible advantage to be able to play a kickback game. Well, then, roughly a decade later, Affordable Care Act comes into play. Again, great legislation. Love the intent. We want more people into the healthcare system so we can help prevent disease and help lower overall health costs by getting prescription medicines or people in the system sooner. So where did it go bad? In order to, I won't say entice, but in order to get the big insurers on board, they had to have some assurances that they weren't going to get forced into a bad business model. So in essence, they got to be able to make 15 to 20% of their spend. Now, when I say that to folks, that usually is like, okay, I don't quite understand that. It doesn't sound good, but can you give me an example? The answer is this, is in order to make sure that they couldn't go bankrupt, they had to have some floor, but then they got to make a profit on top of that. So you'd say, well, if everything's reasonable, that doesn't sound unfair. Making a 15% profit to do something important, that sounds okay. But here's a real world example. Let's say that a patient needs to have a surgery. At hospital A, it's going to cost $10,000 to do the surgery. At hospital B, it's going to cost $60,000. Now let's assume that the quality is the same. Well, every one of us would automatically gravitate to, well, if it's the same quality, we're going $10,000, right? No. If you are the CEO of a large health insurer, your sole fiduciary responsibility is to your shareholders. So if you can make 20% on 60,000 versus 20% on 10,000, you can argue that that's their job. So if you're a shareholder of those large companies, you're saying, hooray, good job. You found a way to make us more money. Keep doing it. Now, if you're the employer or the patient, you are appalled. Why would you make me go spend 60 grand when I could have spent 10? Well, you don't know about it, right? It's baked in your premiums. You have no clue this is occurring. So do health plans like PBMs who force the cost going up every year? Absolutely. If you can force a brand versus generic and force somebody to spend $100 versus 10, I get to make 20% on $10. If you can take a drug that's cost $60 and turn it into $7,000, I can make 20% on $7,000. I want you. And what we saw in the market is they not only liked them, they bought them. Because if you can be the health plan and you own your own PBM, you can basically manipulate your profitability multiple ways. And you get the rebates. So you get the rebates and you get the increase of spend and you get to pass it all along to the consumer. Now, you're going to say, how do people get away with this, right? So if it's a federal government, of course, as if you're a taxpayer and you're on Medicare D, you have no choice. You're just giving what you're giving. Now, here is what I call one of the biggest scams again in world history. Employers. Employers want to give health benefit or health insurance to take care of the people they care most about, which is their employees, right? Again, they're running a trucking company. They're running a gas station. They're running a manufacturing plant. This is complex stuff. So who do they hire? Well, I have to get an insurance broker. So the unfortunate part is I go back to trust but verify. Well, I trust that person. They took me out to dinner. They took me out for golf. They're my friend, right? But I never ask them, how do you make your money? And the answer is they get their money not one, not two, but sometimes 15 different ways. How many employers knew that even a couple of years ago, their insurance broker was making $25 a vial of insulin? They're making more than the local pharmacy. Natural question is, well, why is my insurance broker making money on how many prescriptions I fill? They're actually motivated to have my people take more medicines. Yeah, folks don't know that, right? So why do I bring up insurance brokers after I brought up PBMs and pharma? So now we can bring them all together. PBMs and pharma, because rebate games get to kind of play the shell game. They get the black box of money. What do they need to do to incentivize folks to talk employers into these health plans? Well, insurance brokers are the methodology that most people use to purchase a health plan. Well, we need to make sure they're compensated to do us right. So now they can take some of these rebate dollars and says, I'm going to give it to you, Mr. or Mrs. Broker, because I want you to tell the local employers that our plan's the best. Now, in talking to the number of insurance brokers, and by the way, in each one of these industries, let's say there's the good, the bad, the ugly. So I don't want to paint everybody in the same brush because it's just not true. PBMs, we need them, right? They were formed for a very important purpose that still exists today. They need to perform a function. To pay the bills, to do some infrastructure, and to do the formulary management, absolutely needed. But it needs to be done aligned with the incentives of the employer and the patient. It needs to be reasonable and fair, not gross profiteering because they can get away with it. Same thing with health plans. There's some that are designed very, very well. We'll get into some of the discrepancies later on this docuseries of health plans are actually designed that's almost going to milk you out of more money and contribute to a very, very significant issue we have in our country called bankruptcy. And the same with health insurance brokers or consultants. There is the good, the bad, the ugly there. We'll give you the solutions to the good. And I'm very happy to say that part of what we hope to do in this docuseries is be able to give you solutions because there are really, really good solutions out there. There is free market that's already occurring. Surgery centers that are not affiliated with the health system that have incredible talented folks that can perform very high-level medical functions at literally fractions of the cost. Why? Because they don't have to do the gross profiteering that you see elsewhere. So to be able to summarize this very quickly, Medicare D allowed for a special exemption for pharma and PBMs to create this black box of money. Affordable Care Act allowed for health plans or incentivized health plans to actually spend more. If you spend more and pharmacies part of that spend, I like PBMs to keep raising prices. So health plans and PBMs then not only coalesce, they literally buy each other, they're owned by the same entities. And then take this extra money, what do you do with it? Well, you need to entice insurance brokers to peddle that, right? So pharma, PBMs, health plans, insurance brokers have this kind of four-legged stool that most of us folks that think we're just bound by. And oh, by the way, this extra money, we would all be remiss if we didn't realize the incredible influence they have on legislative issues, right? When you have this much money, you can make an awful lot of influence, especially as complicated as this is. And I bring that up because a classic is, whose fault is it? Everybody does this. And ironically, they're all part of it, right? So, but for Main Street, we have to understand who, what, why, where, and where, how, and what can we do about it. And I'm very proud that in this docuseries, we're going to be able to do that for you.
What was the deciding factor to finally jump into making this docuseries?
So we started this docuseries because of the following. It affected my family. It affected the people I care most, with the people that we built Hometown Pharmacy of Wisconsin. It affected our patients. And we tried to do it the normal way. We went through the legislative process. So I'm going to go in depth on all the above, but legislative process. We were asked by a legislator to actually testify in front of the Wisconsin Assembly way back in 2017 on the impacts that PBMs are making in harming patients. We did so, and unfortunately at that point in time, the Wisconsin legislator was heavily one-sided, and this is not going to be political. I'm not going to go into R's and D's, but just let's say that one party heavily outweighed the other. The minority party asked for this testimony, which we gave, so we didn't expect it to go very far. But it caught the attention of some key folks that says, this is an issue that needs to be addressed. This is hurting too many people. So we were very blessed that we worked with somebody who had worked with a past governor who had done a lot of fantastic things for the state of Wisconsin, and we spoke to him about the issues and the policy. We were very blessed that he believed in this enough. He says, I want to help you get this policy and legislation across because it is the right thing to do for many folks. Now, he did let us know that this is complex, and we met a lot of good legislators. And what we found is a lot of legislators go there because they have a certain passion. It might be environmental, it might be schools, it might be jails reform, but most folks haven't even heard about PBMs, much less to understand they need a reform. So this is complex. So it took about 2 years. We were able to bring facts to the table, and with some other fantastic legislators from both sides of the aisle, there was a new record set. There was 104 co-sponsors out of 133 legislators in Wisconsin. We were intensely proud of that because that was a culmination and collaboration of a lot of good work by a lot of good people, right? Legislators got invested and involved so we could educate. They talked to other legislators, and it was bipartisan. This 104 was both parties, and matter of fact, in one house we had an R lead and a D second, and the next one we had a D lead, R second. We really felt we did this the right way. So after 104 co-sponsors, okay, what's the next step? Well, you need to get a hearing. Okay, what do we need to do a hearing? Well, I don't know. You need to have the health chairs call for the hearing. We have 104 co-sponsors. What's it take to get a hearing? And we were in silence. So we had excellent consulting that said, hey, Dan, do you think patients would be willing to call the two health chairs to ask for a hearing? I said, I don't know, but we will ask. Because the one thing that we're very proud of is independent pharmacies' relationships with our patients is intimate. We build relationships because to help people, you have to build a relationship. Is this going good or bad or indifferent? So that bond is real and significant. So boy, did the patient step up. We told the legislators that we were going to start calling it at Tuesday at 9 in the morning, and by Tuesday at 11, they called us up and said, please call off the dogs. You get your hearing. Just have people quit calling. So there was proof that the people of Wisconsin were willing to step up and says, this is so important, we need to have a hearing. So I got the hearings, and incredibly proud moment because we had well over 90 people show up to testify. Only 72 actually got to testify, and this was multi-hours. I believe it was greater 5 or 6 hours. We had longtime people in Wisconsin that had witnessed hundreds of hearings say this is the most one-sided hearing that they'd ever seen. And it makes sense, right? If you have a patient that's been wronged, who's been ripped off, who's been denied access, who has been manipulated on many fronts, because we haven't even talked about step therapy and all the different hoops that hurt patients. But that's compelling because this is real life people saying this happens to me. Meanwhile, the opposition basically is trying to protect, their turf of $4.5 trillion. Our healthcare spends $4.5 trillion. There's a study done by, I think, Boston University that 75 cents in the dollar in healthcare spent on bureaucracy, admin, and profits. So isn't that disgusting that 75 cents in the dollar is spent on that versus all of us would want our doctors and our nurses and our hospitals and our pharmacists to be paid fairly, not to line the pockets of Wall Street to gross enormous profits. Okay, so the hearing went well. We felt like we were going to get this policy across. 104 co-sponsors out of 133 legislators, there's already more co-sponsors than votes needed. We should be done. No, I was definitely naive because that's not true. So the next step was to actually get a vote. We couldn't get a vote scheduled. And I will let folks determine who gets to make the votes. And I think we all know it's leadership of those houses. We said, what can we do to be able to help motivate to vote? And our lobbyist again says, hey, Dan, do you think your patients will be willing to sign a petition asking for a vote? I says, I think so. How much time we have and how many do you need? Just asking. He goes, well, we only got a couple weeks. Do you think it's possible to get 1,000? I said, based on how the feedback we got from our patients, I think we can do better than that. Well, in 3 weeks, we had 11,632 patients says, we want to vote, we need this fixed. And this is just our pharmacies, right? So we felt like, okay, this is Wisconsin speaking. So we're very proud that we built relationships with patient advocacy groups. We held a press conference in the state capitol, and we had 4 scrolls of paper, 4 feet high, about 8 feet long, that actually had all 11,632 signatures saying, people of Wisconsin want to vote. Okay? So up in this point, we had heard nothing from the speaker or the opposition. And as you were probably already surmised, who's the opposition? Well, the PBM lobby is one. Health plan lobby, AHIP, is 2. That's the 2 that actually own each other. The insurance lobby, those folks who actually get commissions for it, those 3 are tied at the hip. And they are very powerful. They're very, very rich. They're very, very connected. That's the uphill battle, right? And I was soon to learn that that was too much to overcome. So we sat in the speaker's office over 2 days, I believe 18 hours, going through every single line item of the bill, and we watched 90% of it gutted. Just gutted. So things that actually were really going to protect patients and create a fair playing field, gone. Absolutely gone. So I leave that experience going, wow, this whole idea of the swamp extends to state politics. If you don't have money, you're just doomed, right? So as you might imagine, that was not a good moment. It's like, how do you actually solve for the corruption over top, right? And happily, this lobbyist said, hey, Dan, the best advice I can give you is that politics is about MOM. M-O-M. Money, organization, message. When it comes to money, you have no chance. The PBMs, the health plans, insurance lobby have so much money that you independent pharmacies and patients, you have no chance to compete on that level. Message. You guys clearly dominate there because this is real people getting extorted, going bankrupt, and getting sick, and later we find out given the ultimate sacrifice of life because of this. That's pretty compelling. The problem is organization. I said, what do you mean by that? We got to remember legislators, they're good-hearted people, and they come in and they have a lot to do, right? They're the ones trying to solve 100 things at once. And if the only message they hear is from those three lobbies that are powerful, they're saying, well, geez, I hear that PBMs do a service. We hear, and this is the part that those of us in the industry actually want to throw up in our mouths whenever we hear it, that, PBMs are the only one in the supply chain that keep pharma in check. And we're going, boy, that is how does your nose not grow 15 feet long when right there it is in public record in front of the U.S. Senate Committee that insulin that costs $36 ends up $594 because you mandate rebates of $432. Of course, pharma has to add that onto the price. So is pharma the one dictating the price? Yeah, but they have to include the kickbacks they have to pay you. So it's like you're telling 1/10 of the story. The other 90% is where the truth is. So back to organization, he goes, Dan, if it's just independent pharmacy against PBMs, you have no chance because legislators are thinking they're picking one business over another, and that's not what they do. They're there to protect the public good. What you need is employers and patients to be able to be on your side. And we're going, that's the very people we protect. That's who we're trying to help. But if you talk to 100 patients, less than one even knows that PBMs exist. They know something's wrong, right? This can't be right. Why did my $10 generic, why am I forced to a brand? This isn't right. Why does something that cost me $10 3 years ago now cost me $500? That can't be right. So everybody knows something's wrong, but who, right? And a PBM has enjoyed this incredible anonymity. Everybody's heard of pharma, right? And they've heard of doctors and health systems, etc. They just know that it's really complex. Back to the question of why we're doing this, that was one. His mom, message, organization, money. We need organization. We need people to actually know what's going on, because if they know where the problem came from, who the problem are, and solutions, now we can start demanding it, right? So that was one big one. And we were thinking about doing this back in 2020. And then, of course, COVID hits, shuts down the world. Then, next part was personal. My daughter, who I love intensely, she gave us our first grandchild, and the delivery came roughly 5 weeks early. And this is COVID. We can't even go see her. So it is this combination of incredible fear and joy and complexity and anxiety. And she went to a local hospital initially, who said, hey, this is emergency. We're going to have to do an emergency C-section. We need to go to a hospital in Madison. So, okay, whatever needs to be done. And our health plan, we have an agreement with the Alliance, which gives us access to all hospitals in Madison contractually, as well as there's a law that emergency that you have to admit. And at this point, we don't care about insurance. We care about our daughter and our soon-to-be granddaughter, that they're going to be healthy and happy and safe. And then we get this call saying, I'm sorry, UW Health and Meritor are denying admittance. What? My daughter is in the middle of having an emergency in a C-section. My granddaughter's and my daughter's life might be at risk. And somebody's saying they're just not going to admit it because they don't like our insurance. Now, we got blessed in that another hospital dean will be forever grateful because they gave my daughter and granddaughter incredible care. As a matter of fact, shortly after the birth, there was another emergency occurrence that they handled brilliantly, and in my mind, they saved my daughter's life, right? So for there, I'm forever grateful of the caregivers and the nurses and doctors at Dean for that wonderful care, and I'm happy to say they're both beautiful and healthy as a horse today, but I'll be forever scarred that UW Health and Meritor chose to deny entry because they didn't like our insurance because we were bucking the system. To me, that's evil, and they deserve whatever karma is going to occur to them because that was done with intent. Now, I want to make sure I'm very clear. We have friends that are doctors and nurses at UW Meritor that are fantastic, awesome people that will give great care. So please, this has nothing to do with the caregivers there. It is everything to do with the decision makers in the C-suite that says, we didn't like that hometown went self-insured, and we're not going to admit care, especially in life-altering decision. That's just wrong, right? I'm trying to maintain my anger now, but that was horrible. We were told that we had a viable lawsuit, and I thought, you know what? Like so many people, are you really going to fight those behemoths who have an army of attorneys? We're going to find some way to make it somebody else's fault and just go through that pain and agony, live it over again. No, I just kind of believed in fate and in karma. And if this exposure of the truth accomplishes that, so be it. Okay? Now we get into last year's session. There's a couple champions in the Wisconsin legislature that says, Dan, we got ripped over the first time, but we're going to keep on trying. And so there's some really, really good people in government. I want to make sure that I don't come across as being too sour. And we thought this last session that we were going to have Wisconsin make up for the previous wrongs, right? That we would catch up and get the proper legislation in place. Unfortunately, it happened again. In this case, it got slow played and never got a vote. So that is a third. Now, the last is by far the most impactful. We had a call from one of our pharmacists saying that one of her patients, this is actually part of the docuseries, I believe I can use their name, and I'll give the permission, Bill and Shannon Schmittenecht, had a tragedy. And they're just starting to learn about PBMs. Can you reach out to me just to be able to help fill in the blanks, just help them through this time? Well, of course, that's what independent pharmacies do. We take care of folks. So I got invited over, and I got a chance to sit in the kitchen table with Bill and Shannon, and that is, I'll say, 2.5, 3 hours that changed my life, that made this, that we have to do this. They had the ultimate tragedy that should never, ever occur. Their 22-year young boy, who was big and healthy other than his asthma, was told that his asthma medication, instead of being the $50 copay it was a month before, was now going to cost him $536.18, and he had to choose between rent and his asthma inhaler, and chose rent. And that decision ended up costing him his life and created incredible pain for the family and for almost everybody they touched. So I made it a point to myself on the way from their home back to home. I called up my daughter's a filmmaker, says, Mary, you were right. We have to make this film. This has to be done, come hell or high water, because people are dying now. We knew it was going to happen, but now it did. We didn't do enough ahead of time to prevent this, and we're not going to let this happen again. And legislators, I don't care if you don't understand it, or you don't have enough backbone to fight it, or you're getting paid too much. Enough of that. We're going to make enough people know what's happening that hopefully the rest of society comes and says, this is enough. We've seen so many terrible things happen in the last 6 months that shouldn't happen, but they have because so many people are hurting. And they're hurting because they're getting extorted, they're getting ripped off, they're getting manipulated, they're going bankrupt because they shouldn't. Because 3 parties have gotten so damn greedy that they're taking the rest of us for a ride. And now that we know what's happening and that it can be fixed, we have to do this. And that's not 1, that's 2, 3, it's 4 reasons. But you know what? All 4 are pretty darn impactful. And I think the reason why we didn't do it sooner, people are scared. If you are a pharmacist or a doctor, you are scared for fear of retaliation. The name of this movie, Modern Medical Mafia, wasn't by accident. I remember I'm a fan of movies. And when you watch things like Godfather, and you watch documentaries, the mob of the 20s, you think of what must have been like to be that shop owner in New York where you had to pay protection money. How horrible would that be? Then I woke up one day saying, holy crap, we're it. We're getting started every day. We get all these fees and manipulations, and then we're scared to say anything because if we do, they kick us out of network and we can't serve our customers at all. So we have been manipulated and extorted more than people can possibly believe. So it's like, okay, enough. This has to be done. And that's why, to end on a positive note, it's amazing how many incredible people across the country are fighting the same fight. It's not just us. As we reach around the country, there is an army of independents and patients and patient advocacy groups and physicians, folks who actually give care to patients, who are all saying we've had enough. So hopefully we are just one of the arms locked in with others that says this is just one more piece of information that we've had enough, and we're hoping to connect with enough people to say this is what's happening, we can fix it. And we've been asked by legislators that the last thing we need is for enough people at home to know what's happening and call up and says enough. So one of the things you're going to hear time and time again is your phone calls matter. You call your legislator and says, okay, I understand a better thing. We need to have PBM reform. We need to have it where people can't extort and manipulate us because they can. We want a fair. We have incredible facilities, incredible people, incredible technology. We can prevent 80% of disease. Then why aren't we? Because the current health plans are designed to healthcare profiteer, not to actually help people prevent disease and lower cost. Who wants lower cost? Everybody else. What patient doesn't want to feel good and feel better? What employer doesn't want to give more benefits, have their people healthier and happier? Everybody else does, except for the folks who are actually in charge. And you're going to see all kinds of evidence. And the good news is we already know how. We just got to do it now.
What are the different ways that PBMs make their money, including like patient steering, and how are independent pharmacies being impacted by things like that?
That is a great question. And the answer is more than we have time for. We have an infographic. There's at least 51 ways we know they manipulate the system. But more pointed is, you assume that back to them just having to pay the bills, you assume that the pharmacy would say, I need $30 for that prescription, and the company would pay $30, right? And the way it was really set up is the PBM then would get like 6 cents or some dollar for transaction just for doing the service, right? When they did formularies, they also never had to disclose what they're doing. And one of the ways they make money is spread pricing. Okay, hey employer, I'm going to charge you $35 for that drug that the pharmacy would cost you $34. No, by the way, pharmacy, I'm not going to pay you $30 more, I'm going to pay you $25. So they just made $10 by overcharging the company and underpaying the pharmacy. Well, they got away with it. What did they do next year? They did some more, and some more, and some more. So now it's that spread pricing where they make obscene amounts of money. That's just one. We talked about the rebates earlier. The intention of rebates originally was, hey, if I buy 1,000 bottles versus 10, and I'm saving $5 a bottle, common sense, or you would intuitively think, well, good, the patient's going to pay, or the employer's going to pay $5 off the bottle. Maybe less a commission, 5 or 6%. They don't tell you that, no, I'm not going to share any of that. Now, they got away with that being incredibly, we call it black box, it basically means hidden, right, non-transparent. Then, of course, it got in the news. And now what people don't realize is, okay, rebates it's getting more attention, so maybe I have to pass along all the rebates. Sounds good, right? But nobody knew that the contract between PBMs and pharma changed. They morphed. Well, what do you mean? Well, remember that $50 rebate you used to get before? Well, people are getting upset and uptight about those rebates. So guess what? Instead of $50, let's do it different. The $50, let's just call $5 rebate because that I have to give. And I was giving that anyhow. What about the other $45? Well, let's call this a marketing fee, an admin fee, a formulary fee, a setup fee. So it's still going to be $50, but for me to keep that $45 I was keeping before, I just have to recharacterize it and call it something else that the payer has no clue would exist. And because I don't disclose any of this, that's our way of continuing to play the game. So a lot of times, and I always get a kick out of this, because when you go to legislative hearings, people say, well, if you do this, it's like pushing a balloon. You know, if you push on this, it'll come out somewhere else. And in my mind, I'm going, Yeah, but don't you realize that's manipulation? You're admitting in front of everybody doing manipulation. Okay, I'm going to do this on rebates. Okay, I just charge more admin fee. You're not going to know about it because in a bubble, how do you know which? So it's just the shell game. And so much about PBM reform is if people just got to be transparent, right? And so that's one item. You mentioned patient steering. I'm glad you're bringing that up because people hear about it, but it's like they don't know how to equate that, especially how it affects them and their community. So the best way I can say it, and this is intimate. We had a pharmacy we recently had to close down in Randolph, Wisconsin, that had a pharmacy there for 122 years. Did we just get dumb overnight? What happened that could possibly have a business that was the only pharmacy in town, fantastic reputation, all of a sudden not be able to be sustainable anymore? It's called patient steering, and here's how it occurs. So let's say the population of Randolph is approximately 1,800, but in about a 30-mile radius, there's maybe another 1,200, so 3,000 people. So 3,000 people, you can usually have enough to sustain a pharmacy. Well, 7 years ago, the local employer and or Medicare program says you have to go mail order. So maybe there's 300 of those 3,000 people that no longer had a choice. And let's say of the 300 people, 150 used to come to our pharmacy. They can't come anymore. They leave crying. They maybe even get mail order, but still come to our pharmacy to ask for advice on it. So now we give service without having any comp, which we do because that's our community member. Then the next year, 10% more. Next year, 10% more. So unfortunately, the PBMs have been brilliant in killing their competition by death by 1,000 cuts. If it took 50% of our customers right away, that would be too blatant. But if every year for 10 years they take away 10% of your patient base where they can't come anymore, pretty soon you wake up one day and says, okay, there's not enough there to pay the light bill anymore, right? And then you add to it. Then we're talking about the spread pricing. Well, they got more egregious because they found out they can pay whoever they want to pay over how much I want to pay it. Well, if I have my own mail order or I own, in my own retail store, I'm going to pay them this much. Well, my competition there, I'm going to pay them this much because I want them gone. So it is the definition of anti-monopoly practices and absolutely violates, in our opinion, the Sherman Act as well as Robinson-Patman Act, Sherman Act for sure. And now there's a key question. Can a little bitty independent pharmacy take on a big 6 Fortune 500 company, their arm of attorneys? And of course, by their contracts, they make you overcome these incredible hurdles. Now, it's gotten so bad that I'm happy to say there are some things occurring there. But as you might imagine, that's the long, slow, bleed-out battle that they also count on. Hey, these little guys that can't compete with us, we'll just simply out-lawyer them or out-money them until they go away.
Can you give an example of per prescription? It's been said by many people that they make more on a cup of coffee, that you make more on a cup of coffee than you would a prescription. How does the PBM pay off the insurance broker and take that money for themselves, and how much is pharmacy compensated, more to the point of the pharmacy not being able to exist and survive anymore?
So it's a great question because the normal perception is, and we've heard this from legislators, hey, pharmacy is just like a hardware store. And I'm going, well, most businesses have the ability to say the cost of a hammer is this, and then I get to choose what I charge for it, and the market will bear. Well, this is not like that because the consumer isn't dictating the price, either is the pharmacy 98% of the time. 98% of the time, the insurance company says, I'm going to pay you whatever I'm going to pay you, right? So if you're caught, and they have market data, I know that prescription costs you $10, I'm going to pay you $8, right? Now, if I did in all prescriptions, I'd kill you too fast. So if there's 100 prescriptions, on a third of them, I'm going to pay you below cost because I can get away with that. Now, of course, that weakens you to the point where you can't sustain anymore. But again, I need you to almost die of 1,000 cuts versus just being too blatant and just blowing you away, right? And we haven't even talked about DIR fees, which finally became illegal. So independent pharmacies are incredibly resilient. And what I mean by that is I've met a lot of wonderful people across the country. Some haven't taken a salary in 3 years. That's how bad they want to stay alive and do their communities. So they're working significantly under market conditions. Why? Because that's who they are. They were there to be able to serve their patients. And there's a brilliant pharmacist in Georgia who literally testified in front of the Washington Capitol that she makes more per cup of coffee than she did on, I think, 40% of her prescriptions. Right? And a cup of coffee, you can make a margin, maybe making $2 or $3. But 40% prescriptions, losing money. So just think about that, America. Did you ever expect that? And the question about the brokers making more, yeah, because if they're making $4 to $5 to $6 a script, and your local pharmacy is losing $5, that's how gross it is you got all these middlemen. PBM's making the most of anybody. Pharma getting their cut, and we can certainly argue that, and we saw in insulin too much. The health plan's actually getting kickback and rebates, and the insurance broker. So here's 4 middlemen that are making, in my opinion, more than what they are contributing to the system. Meanwhile, the pharmacist there who's in your town, who's paying rent and keeping the lights on and hiring 7 people, actually delivering a service. And the part that those who are customers for independent pharmacies know this, that's an access point for healthcare. Somebody there that actually knows their name and knows how their history is the last 10 years. And a couple stories I'm particularly proud of is I've gotten phone calls or letters from patients saying, your pharmacist saved my life. Well, tell me more. Well, in one case, a patient wasn't feeling good and asked if we could deliver not only their medication, but another item. Our pharmacist recognized that her speech didn't sound normal. Called a welfare check. Went, sure enough, she was having a stroke. So with that, got an emergency ambulance to the hospital, saved that patient's life, because we knew the patient well enough that something was off. And I'm willing to bet that if you talk to 10,000 independent pharmacies, virtually everyone will have a story similar to that. We are a part of the healthcare system, right? We are the most accessible. You don't have to make an appointment. It doesn't cost to go to see there. So I believe this is kind of a concern for national security for a healthcare system, that if you wipe out independent pharmacy, you wipe out a vital part of our distribution system to actually deliver and administer care.
And beyond pharmaceuticals, why are independent pharmacies an advocate for people's health through getting people off of prescriptions?
So pharmacy is, unfortunately, the last 30 years, I think people's perception of pharmacy has been pills, right? The history of pharmacy is so much more. Apple a day keeps doctor away. And in the rest of the world, including the many independent pharmacies, it's pharmaceutical, nutraceutical food. Food always has been, always will be, the best form of medicine, right? A nutraceutical is basically a quality supplement that you can't get by eating your normal diet. A pharmaceutical is meant to be a short-term emergency need. Hey, my body had this issue. I need to solve this now. So whenever possible, you should be wanting to be on a pharmaceutical for a limited period of time and then go from pharmaceutical back to nutraceutical to food. Unfortunately, the healthcare systems, as you saw, if the insurance broker and the health plan and the PBM all get to make money, the more prescriptions you fill, they definitely want you to be prescription only. Pharmacists are the one that says, okay, here's how the pharmaceutical affects your body, but with the extra service, we want to do whatever's right for the patient. So there's the key is I believe we're viewed as a risk because we are the last people that are on Main Street that actually get to have face-to-face conversation with our patients that want to go from pharmaceutical, nutraceutical food to help people not go bankrupt based on their medicines. So if you're a billion-dollar corporation and somebody's saying, no, you're taking that away from me because you're trying to get people off pharmaceuticals, I think they think we're a threat.
And would you say that the PBMs and insurance companies and healthcare systems profit off of keeping people sick, and that's another reason why they don't want independent pharmacies to exist any longer?
Undoubtedly. I mean, the numbers don't lie, right? And the part that to me is really appalling is there now has been enough white paper and science that there is enough knowledge now that we can prevent 80% of chronic disease. Remember the first time I read that says, well, this seems too good to be true. If this is true, why aren't we doing it? Well, because so many of us equate our health insurance as actually being a plan or strategy. They have no idea it is for profiteering for just a handful of companies to make significant amounts of money. An actual plan or strategy needs to be people who says, I want you to not be on prescriptions. I want you to be healthy. I want you to get to root causes. I want you to find solutions. That is not in alignment with profiteering by the big three. So it's an illusion that we've all been kind of, does my card cover it, right?
Can you give the example while also stating that they profit off of keeping people sick? The whole car insurance aspect of things, and you take care of your own oil change, your own engine to make sure your car is behaving or running well, but you rely on health insurance, but they don't call you to make sure you're doing healthy.
A combination thing. So you always got to define what is insurance. So insurance, I believe, was actually first conceived, I believe, in a village in England around fire. Because inevitably, if there was 1,000 houses in this town, somebody had a tragedy. And that poor family was completely robust. And somebody says, you know what? That could happen to any of us. How about we pool our money? And that way, if we each put in a few bucks, if it's our house that burns down, great. We're there and we're sharing this risk. So insurance, by definition, is supposed to be buoyant. It's supposed to be just enough to kind of cover for these bad things occurring. Same thing kind of with car insurance, right? When you buy car insurance, you don't immediately take your car and drive into a telephone pole so you can use it, right? No, we change the oil in our car because we don't want our engine to blow and the worst time and then have to use insurance. So health insurance is somehow morphed into, hey, that's good for me. Instead of like, oh, no, that if it's designed the right way, it could. And so why is fire insurance and car insurance and health insurance different? I think it goes back to anything with the health you want to trust, and you assume everybody there is going to be caring, not want you to go bad. We have no idea the intent, and we don't follow the money to know what's occurring. So somebody asked me once can you equate health insurance with the fire insurance? And I said, yeah, the problem now with our current health insurance system is the people who create our health insurance would be like, back to that fire insurance, what if a group of companies that own the fire insurance company also owned matches in their lumber yard? And now they went out there and lit a match for houses burned down, and now they could sell you the lumber. They get to make you money on the lumber, on the matches, and on the insurance, and premiums kept on going up. Well, that's what you have happening over here. When you have the ability to say, okay, I'm only going to let you see a doctor for this amount of time, for this many time, well, guess what? You're not going to go to the doctors often because it's a hassle. And then when you get to see the doctor, he or she is so darn busy, they only give you 5 or 7 minutes that your experience is no longer what it used to be. And then you find out later that, let's say you have 4 conditions. Then you find out, well, they can only bill 3 CPT codes at a time, so they aren't going to see you in 1 visit. Mary, I need you for 2 because I need to bill you twice. Now, how long does it take for a patient to not feel like a pawn? Mm-hmm. So basically say, I'm not doing this anymore. I'll go home and figure out myself. And at that point in time, you do that until you feel so bad now you have to come back in. And guess what? Now we tell you the bad news. You have a chronic disease because we didn't take care of it all the way through, right? That's one example. The second one is, to me, these next 2 parts are very heinous. Step therapy and whipsawing. And it's one of those where you don't even believe it until you live it. Okay, what is step therapy? Well, doctor knows that you need this prescription and is very confident it's going to get the job done. Call up the insurance company. Nope, sorry, we don't do that. Now, you want to think that an insurance company is on your side because for some reason that really isn't cost effective, that it's somehow your best interest in mind because you assume that they are fiduciary duty, which means they're on your side. And the truth is, it couldn't be further from the truth. They have no fiduciary duty to you whatsoever. They have significant fiduciary duty for the shareholder. So if they can get a rebate on this drug that gives them $100, meanwhile the drug that your doctor wanted you on was only one, they literally now have the power to say, sorry, Mary, I don't care what the doctor says. I don't make enough money there. We're going over here. Well, that got so much bad press. It says, well, we have to have some mechanism. Well, guess what? Step therapy means, that drug we want you on? If you fail on it, then you can go back to when your doctor wanted. So what's fail on it mean? Best case is it does no harm, right? It just doesn't work. But what about the damage that's being done inside of you? The prescription was given for a reason. Something's not working the way it should. So every day that it's not working, it's getting worse. So basically, let's put the patient through all this pain and anguish and let them fail. Sometimes it's 30, 60, 90 days. Now, what's that do to the rest of the spend? Well, instead of keeping this contained, now all of a sudden you might have a hospitalization. You might have something else really bad happen. Well, you think that would be bad, right? Well, the health plan says, well, it's not coming out of my pocket, it's coming out of yours, and I get 20% of my spend. It's the reason to increase premiums. So, because they're fiduciary duties to their shareholders, it's not to you, company, it's not to you, patient. I went. So there's the part that's wrong, is that if there's ever one aspect of our society we want transparency and for folks, you just assume we're doing the right thing, and it would be healthcare. Now, you go back to this. To me, this is another big societal risk that people haven't thought of. Why did people get into becoming doctors and nurses and pharmacists? They want to help people, right? When they come out and they see life is like this, how many people now want to stay be the doctors and pharmacists? We're seeing pharmacy schools yesterday, one shut down, no longer going to exist. You're seeing low enrollments across the board because, hey, you got into these fields because it's an advanced degree. It costs a lot of money to become a pharmacist and doctor because you want to get out and help people, and you find out you don't have a choice. You're not in charge of healthcare. Somebody who's making money is. So at what point in time do we now have a critical shortage of doctors and pharmacists? And people argue it's already happened. It is today, and it'll be incredibly intense and acute in a few years. Why? Because we've let greed get into healthcare versus people. Does anybody begrudge a doctor, pharmacist, and nurse making a fair living? I haven't heard one single person say, no, I want that person there because I need them. They're not the problem. Paying their salary isn't the issue. Paying a CEO to find a way to make their company an extra $10 billion and they get paid $30 million to do it, that's the problem. And it's kind of hard to argue that they're wrong.
How do you feel that affects the national economy?
Brutal. Because, so I believe one of the big three made $25.9 billion through the first 9 months. Okay, think about what that means. How much that was done by actually delivering a service or care that people wanted. It's a fraction. How much of that was done by inflated price gouging and profiteering? A chunk. Now let's think back to all the companies and all the patients that made up that $25.9 billion. If an employer's health plan cost, let's say it's $1,500 per month per member that's married, and it really should have been $700, that's $700 times how many employees that could have been put back into another part of that business. As an employee, if you're making an extra $500 to $700 a month, what would you have done with that? Would you maybe have went out to dinner a couple more times? Would you maybe have went travel? Maybe you get a new fridge? Maybe you get a new car, right? So how many of those dollars aren't being returned into other parts of our economy? And that's where we're about robustness. So you can argue one sector of our economy is sucking out the rest. And then you look at the cost of labor against other countries. Well, in some cases, I believe the healthcare spend can be up to 25 to 30% of the labor dollars. That's huge, right? And then the part of this is the incredible personal cost. So 60% of all bankruptcies in America have to do with healthcare. Of that, 75% are fully insured, right? So here's where it really, really gets tricky and sticky, but I can make it simple. Employers, I believe 80% of them are doing it very good hardly. They're doing a health benefit because they need to. They hire a broker, just do something because I have no choice. It is what it is, right? And they have no idea that those health plans are set up that contribute to personal bankruptcies. Remember earlier I mentioned that, I got to choose between a $60,000 surgery and 10. Well, if your insurance forces you that $60,000 and you are responsible for 20% of that $60,000, do you think that drives people into bankruptcy? If your health plan says you got to spend this many more dollars on a brand because I said so, and you got to pay 20% of it, do you think that doesn't contribute to bankruptcy? So ironically, the very health plans we're putting together is contributing to the people who care about the most actually going bankrupt.
And how would you relate that to when Medicare Part D came through in 2003 to the national economy since then, and the employment status, and as well as consumerism in the last 20 years in the United States?
It's a fascinating question because how did Medicare D affect the rest of parts of the economy? And it's like one of those where I don't think you're ever going to have any studies that's going to have a direct impact. But let's call it about the great enablement tool, right? Because when you allowed a very, very small group of companies to have this enormous competitive advantage that nobody else knows about, because now those PBMs could say, hey, I just got this huge rebate from Pharma for Medicare D plans. Hey, employers, I can share that with you. On the surface, that sounds very enticing. But trust but verify. Do they actually do it? Or do they actually use that as a reason to be able to manipulate? No, I get the sheep in the pen. And what do I mean by that? That sounds good, right? And you have fancy people and smart people that says, okay, you have to give me the best deal out there. Okay. And I do give the best deal out there, but you have no idea I'm still overcharging you. Because he who controls the data, you should trust but verify. And what we see time and time again, and this is talking with sophisticated folks around the country who have very sophisticated health plans, is the ability to actually get data to compare X to Y to know what you're actually paying is incredibly, incredibly hard. And usually it's not even accomplishable because you have one side that says, I really don't want you to know the truth because I'm making too much money. I got to protect it. The part we find fascinating is employers are inherently smart people, right? To be able to run your own business and stay in business, it takes us drive and intelligence. So we're dealing with smart people. A lot of times they'll hire an attorney to maybe negotiate a contract, a lease. The employer probably knows a fair amount about it. They want the attorney to really dig in deep. Okay, they buy a piece of property, same thing. If it's important enough, a lot of times they will hire an attorney to do that. Why is it important? Because an attorney is their fiduciary, meaning the attorney, by contract and law, has to act in the best interest of the employer. What's so ironic is that when it comes to health insurance, which is usually a far, far greater expenditure and a far greater risk, as we'll learn to this, that employers have significantly more risk going forward, why aren't you getting a fiduciary to do that in your behalf? To me, this is such a huge risk area, and the ability that if you do it right, you can save you and your employees a lot of money and give much better care all at the same time. But you need to have a fiduciary that's actually at the start of the process that you know is on your side and is actually transparent with information.
Can you give the examples of the Humalog and relative to PBM executive salaries to where that money is going?
That's a great question. Let's see if I can answer it. So basically, how does all kind of relate? Well, see if this will suffice. Let's say that you and I are making widgets, right? And it costs us $1 to make a widget. In normal parts of the economy, we have to compete with other people making widgets. And usually there's transparency pricing. I can buy the widget at store 1 for $3, store 2 for $3.19, or store 3 for $2.99. I can go check each one of those. Okay? So basically that's classic economics. What will the market bear? And if my widget is better than yours and I can make margin there with competition, then I get to grow because the market says I like what you're doing, right? So let's say that widget now is life-saving, that you have no choice. You have to get a consumer. So that's a big thing off the table right off the bat. I don't have to compete anymore because I have something you have to have. but there's no competition, so I can charge whatever I want, right? So now you can argue that if there's a unique medicine, that pharma used to be in that position, right? And then the consumer can simply say, I just can't afford it, yes or no. So that's the part I think we've all been kind of used to, right? So you bring up insulin, and I want to say that's the part where this really gets gross. The inventors of insulin sold the patent for $1. They knew this was so important to the future of healthcare, they wanted to make sure that cost was not an issue. So think about the very inventors, the folks you'd say they deserve the most for inventing this amazing piece of history in medicine. They even said, it's not about the greed, it's about the patient outcome. So why is it, nearly 100 years later, they got 3 companies that can manufacture a vial between $3 and $6. Why is it going for $594? Something is grossly wrong there. And the key is, to your point now, you're able to manipulate the market. So, hey, Mr. CEO, if you can find a way to take something that costs $6 and turn it to $594, I'm going to pay you really, really well. Okay, how do I do that? I got to find a way to force the end buyer for somebody to pay the $594. Well, how do I do that? Well, I need employers and governments to pay me that. Well, how do you do that? Well, we have to have these contracts that are nebulous. It's proprietary. How do I get employers on board? Well, how do employers buy health insurance? Well, they do it through brokers. Well, we got to pay them. We got to give them incentive to do this. So that's why I go back to that human log of insulin is right there. This isn't just Dan saying this. It's just me taking history that was actually presented in front of the U.S. Senate and says, here it is. So there it shows a manufacturer getting $135. Well, if it costs them $3 to $6 to make, that is an incredibly high profit margin. If you're the manufacturer, where else are you going to get that? If you're making a widget and you have normal competition, you can't make margins of 10,000%. You need the system to do it.
And so with pharmaceuticals and life-saving drugs or positively life-altering drugs, how have PBMs created themselves as an oligopsony, and how have they been able to manipulate the system so intricately, to your points?
I think almost everybody's heard of a monopoly. A monopoly, only one show in town, the only one selling it so they can make their prices. And we already know that history, monopolies are bad because they can basically hold entire economies or societies hostage, right? That's why there's laws. Sure, you can't do that because you can't rip off all of society, right? So, but most people haven't heard of a monopsony. A monopsony means I'm the only one that buys this, right? So if I'm the only one buying carrots and I get to buy all of them, now I kind of have a monopoly de facto because I'm the only one selling it, okay? So most folks haven't heard monopsony, or they have heard monopoly. So now we go to oligopoly and oligopsony, okay? It's the same thing, but instead of one, it's 3. I shouldn't say 3. It's a small group, but in this case, there's 3. So if there's 3 of them, hey, we're not a monopoly, but there's 3 of them that basically I own 80% of the market selling, and I get to purchase the drugs. So that's what's unique here in this healthcare is, in essence, they can tell some of the manufacturers, and I'm going to go, let's separate this into the unique one-off life-saving drugs, of which there's a small subset. Let's go to asthma inhalers and insulin that we all know has been around for a long, long time and a great number of people are on. That's where we're getting ripped off the most, right? There is a case where if you're making something for $3, you would expect the price to be somewhere between $9 and $35, right? And because insulin, you have to transport, etc. There's cost to get it from manufacturer to retailer to this. But so $35 that Congress eventually got it to, that's more reasonable and fair. And more importantly, it doesn't bankrupt the rest of society, right? But to have an insulin going to $290 to $594 where people can't afford it and they die, right? I mean, lack of insulin, that affects, and again, I'm not a pharmacist or a doctor, this is listen to smart people. You can start having body parts that have to be removed. You can have eye issues, all the way up to death. So it's really, really bad when you don't have insulin the right way. Same thing with a distal inhaler. A young man died because something that probably cost $5 to $10 to manufacture that maybe should cost $60 to $75 goes to $5.38 where people can't afford it, so they die. That's manipulation. That's gross. That's the opposite of what healthcare is supposed to be, but it is today because of the manipulation of these middlemen. So an oligopsony is, instead of monopsony is one party. Like let's say Walmart could buy all the carrots in the world, right? And nobody else could buy carrots. Well, nuts. Now we can't even sell carrots because we can't buy them. So an oligopsony is the same thing. Instead of it being one company, there's only three. And that's the problem. What happens now is if it isn't exactly a third, but it's 80%, if there's only three players and you're a manufacturer and you're going, I have to get on their formulary, right? Because if I'm on their formulary, at least I got a third of the market. So what will I do to get in the formulary? Well, I got to pay formulary fees. So in other words, you almost have to bribe them to be on the system. New York Times had a brilliant article that happened just literally, I think, yesterday, December 16th, that they did a deep dive expose that proved that opioids, you want to talk about a national crisis and having deep impact and the epitome of ugliness. So first of all, extorting people for insulin, to me, is unconscionable. That is absolutely evil, right? Extorting people for their Advair inhaler, also evil. If it's possible to beat those two, it happened yesterday. So, as we now know, opioids are extremely addictive, absolutely ravage families. I believe 15% of people who ever on Oxy once become hopelessly addicted for the rest of their lives and will do anything they possibly can, which damages communities, families, livelihoods, creates carnage. And we've seen around the country. To get to be where they were, the New York Times article basically states that the manufacturers of this paid extremely large rebates to get on formulary for PBMs to carry it. So the very people, to really put this in perspective, to be in the formulary, companies are hiring people to say, do my formulary for me, assuming that you're doing it, for lack of a word, for the right reasons, right? And we're going to get back to one of my favorite interviews of this is a class action attorney who will talk about fiduciary duty. And actually now is a great time to bring that up. In healthcare, there is an inherent expectation. There are people that are there to do the right thing. They're there to do the right thing by you, patient, right? And it's our time of we're at the most duress of any point in time, right? If you're in the emergency room, you're not thinking straight. You're thinking about trying to either survive or overcoming something that's incredibly traumatic. That's not the time you want to be asking people 100 questions, says, can I trust you, right? And nor when do we pick vendors to give our health plan, there's an automatic assumption that you will be doing the right thing. So when it comes to a formulary, you're kind of saying, well, of course, you're going to do the right thing. But now to find out that formulas were actually managed such that you took incredibly large sums of money to keep on something incredibly addictive, and this inflamed the carnage that occurred, is just absolutely unconscionable. So when the FTC announced they were suing the big three for insulin manipulation, it was like, it actually renewed hope. My opinion of the FTC is dramatically altered in the last 36 months. When the very first merger took place that allowed insurers and PBMs to merge, we were all saying this is going to have a really bad ending. And at that point in time, the FTC said, no, bigger is better. Bigger gets more efficiencies. We're going, you just don't understand. This is going to end badly. And they continued to double down and kept allowing these mega mergers that these things getting worse and worse. Now, I'm very happy to say that the work that the FTC has done the last 4 years has given us renewed hope that the FTC is actually going back to its core mission, which is you're supposed to protect the consumers. Federal Trade Commission, basically, that consumers treated fair, that we can't get abused by monopolistic practices. To me, Lena Khan is a modern-day Teddy Roosevelt. Throughout all this, you might imagine you see so many dark characters that when you actually see a hero, it's nice to kind of point out. And the fact that she has so many people that have kind of thrown darts at her makes me admire her even more, because it takes incredible tenacity, mental toughness, and character to stand up to continue the right thing. They initiated a 6B probe about 2.5 years ago. Last summer, they released the initial findings. And basically, the initial findings stated that PBMs have manipulated prices that have hurt consumers and have squeezed Main Street pharmacies. So what we've been kind of telling people for the last 10 years, they studied and said, yeah, we're right. Matter of fact, it's even worse than we thought it was. So very, very pleased. Shortly thereafter, the House Oversight Committee, led by James Comer, and some very, very key folks in the House of Representatives, namely Betty Carter and Jake Auchincloss, had done incredible work to continue to inform people of what's going on. And they held a House Oversight hearing with the 3 PBMs and asked some very pointed questions, and had over 140,000 pages of documentation that also verified they were vastly overcharging patients and squeezing Main Street pharmacy. Then after that, the FTC announced they were suing the PBMs over insulin manipulation. So now they're starting to act upon it. Now the rest is speculation, but with the New York Times article coming out yesterday that the same thing happened with opioids, I'm praying that the same thing occurs there, because public justice does need to be served.
So, and how would you relate PBMs to Pinocchio, and which ways have they lied in front of the FTC?
Oh, I believe they are absolutely brilliant at misdirection. They will tell a fraction of the truth and even sometimes blatantly lie. So at the House Oversight Committee, they were asked point blank, do you patient steer? And on film, all 3 said, no, they do not patient steer. I believe that every single independent pharmacist that watched that had their jaw dropped to the floor, saying, how could you possibly have the gall to say that, and why isn't your nose growing, and why aren't your pants on fire? Because we've experienced literally dozens. We've had our patients get letters saying, you can't go there anymore. We've had folks come in crying saying, I just got called, says I can't come here anymore. Heck, on government websites, you can't go there. You have to go mail order. Heck, we've literally had a case where a patient filled a prescription, was still in our pharmacy when the patient got a cell phone call in our pharmacy asking the patient, why did you go there? Why didn't you go to the one they wanted you to? And then actually chastise the patient for not going there, and then actually give us a call afterwards, says if we do that again, we're going to get kicked out of network. So I mentioned fear of retaliation. That is real. I believe that the vast majority of pharmacies have had some form of, most folks won't believe the following, and it has been illegal, even though most folks don't even know it. It's called a gag clause. So a patient comes in, and the latest scam is some of these cards, right? Hey, I got a card, and if I get this, I get a better deal. And we're going, yes, but you have no idea that if you just ask us our cash price, we're always going to be better in this deal. Well, then why aren't we transparent with our cash price? Because we can't, because we can actually get kicked out of network if we are actually telling people that they can get a better cash price than their copay. So literally times where a patient can come in and their copay might be $50, and we'd say if you don't run through insurance, your cash price would be $20. I mean, it's hard to fathom that could be true, right? Like, who would ever think that would be normal? Because that's you think that the insurance company is on your side. So they don't realize that the $50 copay, they're actually pocketing $50, paying us $15 for a drug that probably cost us $13. Right? So we're happily sell it for $20, save the patient $30. We actually get a margin that lets us pay the light bill, versus that $1 that gets us out of business faster.
Can you explain to the everyday American what a network means and why it's important for a pharmacy to be within a network for a PBM?
So for a PBM to be able to have a contract with an employer or a federal government, they have to be able to prove that they have a network of pharmacies to serve patients, right? Because if a PBM, let's say, only has one contract with one pharmacy in Somerville, USA, but all the population lives elsewhere, they're going to say you don't have an adequate network to service people. So they're supposed to then negotiate and have an agreement with enough pharmacies across geographic regions to make sure they can serve everybody. So if you're an employer that is, let's say, in one county, but live all the county and you got 8 cities, well, ideally you would have a pharmacy in all those 8 cities so it's convenient for your patients. That's what you think intellectually, and you would think that you should pay everybody the same, right? Okay, that would seem fair, and quite frankly, that's the way it should be. So what's reality? Well, let's see, what can I get away with? Well, if a pharmacy is within 70 miles, then I qualify for my network. So heck with patient access. I got my own pharmacy here 59 miles away in a different county. I don't need any of these folks. So now, patient, you have to drive by 8 different pharmacies, including the one you want the most, and have to drive 59 miles if the radius is 60 to go to the pharmacy that they want you to go to. And then because you just have a copay there, you have no idea that your premium's actually growing more rapidly because they're making you drive to pay a higher premium, but they fool you because they make the copay $5 less. And there's no way for you to know that if you actually did it the right way, the most efficient way is have somewhere close by and to be able to lower your cost, and they're paying their pharmacy $100, they would have paid the local independent $50, but they're making you drive extra to pay more, but you never know about it.
And so with the negotiations with these independent pharmacies that would be closer and make more sense for these patients, what contracts do the PBMs give these independent pharmacies that relate to take it or leave it to where they don't have the option to serve their patients better?
So you said it perfectly. These contracts are take it or leave it. And ironically, based on the Sherman Act, that makes them unconscionable, therefore should be illegal, right? But we've heard the term too big to fail many years ago. In this case, it's like too big to jail. And here's the whole definition of a Sherman Act is it was supposed to prevent the ability for a big business to absolutely bully a smaller business, especially if it hurts patients. That's exactly what's occurring. So what they can say is, okay, I want to make more money, so I want to force you into a pharmacy I own because I'm a health plan and I'm a PBM. I have to make money from my shareholders. So I can make more money if I send them 59 miles away to my pharmacy that I can charge more. Well, those independents that are in between there, that's a problem because people keep on telling me they want to be in there. So I have to offer a contract. Well, I don't want them offering the same contract I'm paying myself because that would be fair competition. No, I'm going to pay you $10 under cost on a third of them. On 2/3, I'll pay you $3 over cost. So you might serve that whole patient and work your butt off and make 50 cents. Well, they chose not to take it. Well, I'm still within 60 miles. They chose not to take it. But they certainly don't tell the employer that I lowballed them. I didn't really want them there. I make more money that's over here. So that's what's been going on for years.
And these gag clauses are included in these contracts?
Well, gag clauses were federally illegal a number of years ago, but it didn't matter because there's no teeth to them, right? On many states, there's been gag clauses. The problem is you need to have state agencies actually enforce them. In a lot of cases, it is a case of he said, she said, but I'll go back to fear. You will find the vast majority of cases, you'll hear 0 complaints because an independent pharmacist says, I know if I complain here, all I'm going to do is get on a hit list and they're going to kill me faster.
And so with that, can you express what predatory audits are, where those examples of DIR fees come in?
So predatory audits basically is another method to make money. You're looking for, whenever you hear audit, you're thinking somebody was naughty. They did something inappropriate, right? So you hear the legislator says, well, Dan, you should get audited for malfeasance and doing things incorrectly. Absolutely. But that's not predatory audits. Predatory audits is, okay, this actually happened to us. A doctor gives a prescription for insulin. And the dosing, correct amount, correct thing actually went to the patient. So exactly what the doctor wanted and the insurance cover was there. Predatory audit. Oh, here's a box. The doctor is supposed to fill out how many months or years this patient is going to be on insulin. Well, doctor left it blank. Hey, doc, can you fill that out? Well, hey, pharmacy, how long is that patient going to be alive? I'm not filling that out. You know better. Yeah. Well, so now because a box isn't filled out, it wasn't right. We're taking all the money back. Nothing to do with a valid prescription at a valid price at the valid quantities, etc., etc. It's basically a typographical or some type of procedural issue. Heck, we've had cases where they will be tricky. Hey, a month's supply. Well, if you said a month of supply to people, what's that mean? Is it 30 days? Is it 31 days or 28 days? Depends on the month, right? Well, they change it up on you. For this prescription, it's 31. Another one, it's 30. Another one, 28. Well, the packaging for this particular medicine comes in 30 pills. So it might be a packet with punch out where here's 30. So really, you're going to make us take out 2 and give 28 and make that patient come back at day 29 to redo this again and create all this incredible inefficiency. And they do it because they know the vast majority says, just take the extra 2 pills on us. That puts us at risk for predatory audit because we actually gave 2 extra pills to the consumer. So when you talk about, I go back to Modern Medical Mafia, right? It's almost like the bad guys are trying, what can we do to fleece you again and again and again? And you'd say, well, why don't more people complain? Same thing. If we're fearful, if 3 entities can say, we are going to kick you out of network and you can't serve another third of your community, you have a tremendous fear stick, right? And with that, you get people to basically live with all these abuses until they either don't exist anymore, which is, in the last decade, a study came out last week that 30% of all pharmacies have died in the last decade, and that's going to go much faster going forward. Now people can understand why.
How would you relate PBMs to the mafia in relation to lack of transparency and regulation?
It's interesting because I was born in the early 60s, and in the 70s, etc., you had federal legislation called the RICO Act, Racketeering Influence Corruption Act, right? It was meant to be able to catch the mafia because they were sophisticated, right? They had a bunch of rackets and schemes. And I think if people go Google search it or have AI, they'll say basically racketeering is a method of appearing legal, but doing a fraudulent scheme for profit that hurts the general public. Well, this is it. This is it. When you're able to have people have no clue that they're being forced into a higher priced drug, that you are able to exert your middleman influence. Let's go back to insulin. How is that not a form of corruption? You're taking something that costs $6, artificially inflating it to $5.94, so you're able to get a big rebate to line your own pockets, and along the way you're actually lining the pockets of 3 other parties, all that's absolutely harming and literally can show a direct correlation to killing people. I mean, to me, this has been... I really like one of the quotes we have is, mafia is small ball compared to what PBMs have done. So to me, it's like, this is the definition of racketeering. So I was in a hotel room and was snowed in and put on the History Channel. And it was the great kosher chicken scandal of the 1920s by one of the big mafia families. And as I'm watching that, I'm thinking, wow, this is kind of what PBMs do. So what is a kosher chicken scandal? So basically it was a case where I believe there's only 5 rabbis in the city that could perform the ceremony to make the chickens kosher. And the mafia basically had the distribution system for those chickens, and they raised the cost of that chicken by $1. And they gave a nickel of that back to the rabbis, right? And now they overcharged consumers by, in that case, there's still millions of dollars because they basically had this chokehold that for all the folks who wanted kosher chicken, they were going to pay that extra $1. The mafia was going to pay for its cost to distribute that, as well as a nickel to the rabbis. And as I'm watching this History Channel documentary on this, going, that's what we're living in now. The PBMs are able to take extortion, take insulin, this higher price, pay different folks to make this allow to happen, and the rest of us are absolutely getting hurt. Only this isn't just kosher chicken in one city. This is life-saving medications across an entire country.
And how would you relate those rabbis to legislators, to insurance brokers, to manufacturers, etc.?
It's funny, back in watching some of those movies, The Godfather. So you had to have legislators, and you had to have judges, and you had to have the police force, etc., all part of it, right? Because, and I don't want to cast evil on everybody, but everybody has thoughts and needs. And I look at key parts of our society now, and I realize, okay, I've dealt enough with legislators that I'm going to call them the great, the good, the ugly, right? There are some absolutely phenomenal people that I've met there that I said, I'm glad that you're leading our country. So I'm going to make sure clear there's some folks that meet that category, and it's like, thank goodness, because we have a complicated country to run. The other part I've learned is that a lot of times their first day of the job, they might have to be working the phones to fundraise. That the business of legislating is pretty darn expensive, and I think we saw this last election cycle, incredible amounts being, so we all got bombarded. So where does that money come from? I'm going to argue that us Main Street mom and pop shops who are just making, I'm going to call it a normal living, or even not that great of a living, we don't have the money to put into that except for a couple bucks at a time. So where can you? And I would argue one of the biggest factors in our history is the Supreme Court case of Citizens United, which basically says corporations, you're your own entity. You can write whatever check you wanted to. Oh my goodness. So now if you are a major company that profiteers off this, you almost know that you're going to have to designate a portion of your revenues or these profits. So I mentioned earlier about one of those companies making $25.9 billion. That's net profit after everything. These folks have an incredible amount of attorneys. They spend an incredible amount on lobbyists. And I believe that there's a couple websites out there that shows donations. Let's just say the three areas I mentioned, they are competing for the Super Bowl championship every year for the most lobbying dollars invested in legislative influence. Now, before I make this sound like it's just a pure swamp type thing, there is enough people that and legislators do not want to be in the wrong side of an issue. And being this for 21 years, here's my perception, which may or may not be wrong. The vast majority of legislators are completely confused in this issue. And they have been for a long time, right? And who wants to believe that this kind of corruption and deceit could occur, right? As a matter of fact, a lot have been courted. The question earlier is like, okay, do they do lies and misperceptions? They absolutely do. You can go on in numerous hearings around the country, and one of the first things they beat the drum with is, we're the only good guy here that's actually looking after pharma, that we're the only ones controlling price, and we're the only one that's motivated to keep prices down. That sounds good, and that's who you're supposed to be, but you certainly don't do it or prove it. But if you're a legislator, how do you know the difference, right? It sounds good. Especially if the next interview you have or next meeting you have is with a health plan, and they say, thank God for PBMs. How is a legislator supposed to know the health plan's actually getting part of the kickbacks, and the health plan makes more money the more the PBM charges? There's no way for them to know this, right? And then the next meeting they have is with the insurance broker saying, boy, I'm out there, busting my butt on the streets, and thank God for PBMs, or it'd be even worse. The sound bites sound good, and if a legislator is sitting there saying, okay, I got 15 more meetings, I have 15 different things I know about, that seems to make sense.
So how would you relate that to your experience with the senator staffer that you talked to?
So the one thing that I've found in talking to legislators, and a lot of times is key staff members. There's a part is legislators are brilliant people, but it's way, way too much for one person. So they build a team of other intelligent folks who build the staff, and inherently there's usually somebody that's in charge of health. So I believe in the last 20 years, I've probably talking to 4, 5, 6 dozen, probably close to 250 now, either legislators or aides, to a point where I almost put them into 3 categories in my head in the first 3 minutes. I'm going to call the just, right? They say, I don't understand this, let me ask questions. So those are the fun ones, because now you can inform and give them logic, and they need more than words. They need data and facts. And there's so much data and facts now. It's okay, here's the FTC study, here's the House Judiciary study, here's New York Times, here's the state. So there is so much information to validate our point that's the easy part, right? So now you can tell if they're engaged. We've also learned that it's almost too much for one sitting, that sometimes it takes multiple conversations to say, okay, I can't tell you 51 things because you're not going to believe all 51. Let me just give you 1 or 2 or 3 or 4 or 5. And I'm happy to say after 7-10 years, and this isn't just us, this is other brilliant pharmacists and activists around the country who've had their own relationships, who've done a brilliant job. Sometimes it takes 3, 5, 6, 7 years in a relationship to continue to build, because we are trustworthy. We're the ones on Main Street living this every day. And our motivation is usually the same one of the legislators. We want to be an accessible part of healthcare, deliver healthcare to their constituents, right? And we want to survive. So that's one type, is I'm going to call it the just. 2, which is a small fraction, but we love them, are the champions. And in that case, so many of things happening in healthcare are affecting so many families. Inevitably, it's hurting the legislator's family. So all of a sudden, tell me more. This happened to my wife. This happened to my daughter. What else don't I know? Now that's fun, because you can say, yep, this was a version of step therapy. And by the way, they do whipsawing and. Really? And then those folks are looking for what's occurring and how I want to fix it. So I'm very happy to say in the last 5 years, the number of legislative champions has continued to grow, because who isn't going back to their home base and hearing that prescription prices are too high and healthcare is out of control and healthcare is broken? I mean, you go anywhere on the internet now, and that's like constant theme. Recent tragedies included, right? That the amount of pain out there and what it's having people do is just, it's shocking, yet you see like inevitable, like that people are getting so hurt and upset. What do they have to do to be hurt? And then there's the third, where it's almost like I can tell that you are a legislator that is significantly influenced. And I'm using that very nicely. And you can almost hear, well, we don't want to get it in between contracts, between 2 parties. That's against our philosophy. Really, it's against your philosophy that your patients are getting started and getting forced bankruptcy because people are profiteering, taking a $3 medication turned to $600. You're against that? So we just know that's party speak. And, we had a recent one with a senator staffer who was particularly appalling, because we thought we were going to have a chance to sit down, and we had a boatload of key points. And before a full sentence even came out of my mouth, she came with a retribution, or a counterpoint that was skewed, and then even discussed that, hey, that you provide data for a point of view, which welcomed. Never got it, right? But welcomed. And it was interesting. After 20 minutes, you just saw, okay, there was no intent to learn. There was no intent that you could tell in this particular staffer's mind that she knew all the answers, and nothing I was going to add was going to add any insight. So that part is always interesting, because I'm always kind of curious why. And, this particular senator was really unfortunate, because there was a bill that came out of a Senate Health Committee that got voted out 26-1. And unfortunately, our senator was the only one to vote against. That was unfortunate. Now, continue to educate, and there may be some breakthrough there. And the reason I bring that up is I'm sure anybody listening to this is, we just can't make a difference. And the one thing that we've heard over and over again is, yes, we can make a difference. At a state level, up to 4 phone calls makes a difference. At the federal level, 40. And this negative situation I was telling you about, not all the way there, but now all of a sudden, recently, because more and more information, I started seeing responses like, okay, maybe I'll reconsider, right? Maybe I should. So I think it's like the champions, awesome. Give them information. Let them talk to other legislators. The just folks who ask questions, keep giving them information. The hard eggs, the other part is there's now ways to be able to find out where they get their campaign contributions from. And if you see significant dollars come from certain areas, I think all we do is tell the truth. There's a PBM bill here, but you have significant contributions from that lobby, then maybe you ought to recuse yourself. Or, hey, the rest of the world, constituents, now that you know that, you make your decisions accordingly. Should they be your legislator going forward? And or, hey, if before this sounds overly negative, we're living in a time where probably 2020, before we started making this, didn't have much hope. It felt like that we were severely outmoneyed, and it was just going to be too much to overcome because there's too many of the swamp-like forces. The last 6 months has provided new hope that you actually get the FTC and the House Oversight Committee and senators and even recently elected president going on TV saying the middlemen are part of the problem, we need to take care of it. Wow, 10 years and enough people speaking make a difference. And I think the number one goal, passion we have this is really educate, enrage, and engage. We want you to know what's happening because once you know it, we're pretty sure you're not going to like it, but you're going to understand it. Enrage, that's not going to be hard. When people are literally dying or going bankrupt and they shouldn't, if you don't get mad, then be unique, right? And then finally, engage. Really, one phone call, one email makes a difference. If you're willing to sit down with folks or call them multiple times, we can make a huge difference. Imagine if 1, 3, 5, 10 million people call their legislators and said, enough's enough, we need to finish this. And last but not least, how many of us are employees? You'll find out by watching this docuseries that you actually have rights, you have abilities, you can ask the right questions, and your employer, who most likely is just not aware this is occurring, by making them aware, they can actually give you a better health plan at a lower prices that actually are aligned with taking care of you. If we can be even one iota of help in that change, then we will feel all this endeavor was worthwhile. So educate, enrage, and engage. Let us know if we helped in any manner on those 3 items.
Why do you feel like independent pharmacies gather together to fight this fight, and how have they done so in the last 6 months to make progress?
So independent pharmacies have a calling that's a bit different, right? They got into pharmacy to serve patients, communities. I can honestly say this with all our pharmacists, money isn't their number one driver. Yes, they want to take care of their families, they want to be treated fair, they want to have what their education prevails. But if you said, hey, this medication is going to cost the patient $10 more than this other one, they will always do the lower cost the vast majority of the time. And you got to remember, these are people-to-people relationships. When you see that same person at church, at school, at the grocery store, at the gas station, it's just different because your job is to be in that community to take care of them. And that's a responsibility they take very much. Almost, it's not only an oath that they take when they graduate pharmacy school, but they kind of live it every day. So when they saw this occurring, and it's jeopardizing everything they hold dear. It's jeopardizing their patients, it's jeopardizing their communities, it's jeopardizing their ability to make a living, all at the expense of those 3 that they care about. And the benefactor is, we literally call them the evil empire, right? When people are making more money by being middlemen doing nothing, and it's harming patients, local community, that gets you riled up. So, and it's hard though, because these people have full-time jobs trying to run that pharmacy, so to get out and advocate is not easy. It takes a special person to do so. What I love about this is independent pharmacies are filled with special people. These folks have, across the country, have come together, right? And there's many times where each one of us feels like we're alone, but it's very invigorating when you actually get together and says, wow, there's other folks who want this to kind of occur too. And this has not been a sprint. I mean, there's folks who have been doing this for literally 20 years. When that first merger was allowed, when CVS and Caremark was allowed to exist, there's a boatload of us that says this is inevitably going to be a terrible thing. And now to be proven right is frustrating, but they tripled down on it. They let it happen 3 more times. Now, how do we unwind it? But we are. Slowly but surely, in the last 6 months, there's been more occurred than the previous 15 years combined even.
And how do you feel patients have advocated for themselves and can continue to advocate for themselves within the next year to push reform, transparency?
You know what? I think there is an incredibly latent appetite. I think there's been literally millions of people that have been hurt. But I think the vast majority don't think they have an option. It's always shocking when we talk to a patient and says, hey, did you file a complaint? Really? I can file a complaint? Where do I do it? How do I do it? And so there's so much naivety that, and I didn't even know, right? Because I really even can complain to the officer of commissioner of insurance. I didn't know that. And so part of it is just education. You can have a right, you can complain. And I've met folks from those in Wisconsin, and I'm happy to say I think that they're legitimately good people that want to do so, that they know something's wrong, but they can only answer if they get enough complaints. And what's been fascinating, and it's ironic we're part of it, is there's also a boatload of fear. Because there have been many patients who will talk about this, and at the end, well, I don't want to get kicked off my insurance. I'm told if I do this, I'll get yelled at, or I can't afford to lose my insurance. So basically, there's so much fear out there that patients and pharmacies a lot of times don't complain because of fear of retribution.
And you don't have to comment on this, but with recent events with the CEO of United Health and the public commentary, how do you feel that reflects how Americans have been treated?
So, that's one of those where it's a dark day, right? I think as I always saw this, we're like, we're not quite believing what we're seeing. It was a cold-blooded murder, right? And it's like, oh my God, right? And then you're thinking that, man, the public response to that was eye-opening, right? Now, my heart goes out to his family. Nobody, that's just not right on so many levels, and it should not be part of our society. There's got to be a better way to handle our issues. So that goes without saying, but it was absolutely amazing watching the public sentiment afterwards. The amount of pent-up anger and hurt and pain is palpable, right? I mean, the topic of conversation will come up and says, what do you think about that? And I purposely didn't want to comment because that's a tragedy. There's no way you're ever going to try to spin that to being a good thing, because it's not. But you mentioned a good point, is it did so that, wow, the public sentiment was harsh. It was, I think it's actually maybe been a part of the fact that we're seeing in DC is, wow, this is a much worse problem than people realized. That the pain out there, that people were willing to go to those extents. And that's where you wish in our society people had enough hope that you could solve issues another way. Mm-hmm. And clearly they don't. If he felt that that was his path forward to do that, it's like, have mercy on his soul, because that's a pretty ugly thing to do. Mm-hmm. But the rest of us probably ought to wake up and says, okay, this is a problem we need to solve. I'd like to ask questions and see what other people are thinking. So I've asked that question, and I am reminded of how hard it is to be a legislator, because everybody has an angle. And was fortunate enough, I think about 10 years ago, went out to DC, and it was called a legislative fly-in, and we had a very, very well knowledgeable person kind of explain to us how Washington works. And a couple things they said really resonated. One was, okay, the House, their job is to be able to follow rules, policies, procedures, and try to write bills, etc. And oh, by the way, only 0.5% actually make it to law. So that means 99.5% don't. Then when she talked about the Senate, she says most people don't realize the Senate isn't about passing bills. The Senate is about to not pass bad bills. So I thought that really resonated. So their job is, okay, why I should not pass this bill, why should I? So that makes the bar this high. And it kind of makes sense. You don't want to watch it flip it. So So to answer your question now, I think they half expect when a bill comes that somebody has an issue they want to solve. Is that enough to make it happen? So I think they probably have to look at things societally and from as many angles as possible, right? So for so many years, the cost of healthcare and drug pricing has been a big topic for decades now. right? And it's been so complicated, so convoluted, that I think there's never enough understanding. And oh, by the way, if you have the right influence lobbyist and you're told mistruths like, well, we're the only one that tries to help, if it wasn't for us, it'd be worse, that fear alone might be enough to say, I'm not going to do something because I don't want to deal with that fear. I don't have time to find out if it's true or not. And by the way, the only data I see is from the ones they make up. So there's all kinds of fancy reasons they have to not do something. So to answer your question, those guys have continued to sing song and dance, but it's getting tired. Enough of patient advocacy groups and pharmacists and doctors and have been keep on accumulating data. So I think that we've had a chance to say, okay, what they've been telling you now isn't the truth. And oh, by the way, FTC study, etc., is there. So I think we were almost close to like getting something happening. So now when this tragedy occurs, I think it's a unique insight where legislators can say, okay, how big of an issue is this? And, heck, it was on the news nonstop for X amount of time, and you saw that public outcry. So this is only me, listen to folks, that's like an echo chamber that, holy smokes, this is a huge problem. Will this be a one-off event? Is this a da-da-da? Or is there so much anger here that we're going to have a much bigger problem going forward? And so I'm kind of going as I think before the truth was catching up to the misdirections. And now this is one of those events where which way is this going to go? Is it going to create sympathy over here or there? It's like, wow. So we'll know our answer here probably before this docuseries even hits the air, right? Because there's talk about actually having some form of PBRM reform in the year-end omnibus package. It has a lot of fantastic tentacles, but I'm going to call it the key ones that really kind of matter the most. We have already seen in previous legislation that it gets ignored. There's many great state laws that, quite frankly, PBM says, we're not going to do it, sue us. And they wait for multiple years, keep on doing the indiscretions or breaking the law, counting on that eventually the states will either give up or they'll win a district court, etc. Second part is a lot of times there's really no teeth. It's kind of like, hey, Mary, if you speed and it costs you 10 cents versus you speed and it costs you $100,000, you might choose not to speed if it's going to cost you more than you really want to spend, right? Well, so 1996 is intended to, I think, play offense and defense at the same time, which I really, really like, right? The first is, wait a minute, you guys are doing something illegal that we're going to make clearly not, which is to purposely pay your competitors under market value to get them out of business. That's anti-monopolistic, etc. Instead of them going through the courts, we're making clear you have to pay basically have to pay our cost, plus our cost of dispense, plus a small profit. So basically it says we're not going to get rich, but we have a chance to actually be sustainable. That the competition can't literally purposely undercut us to drive us out of business and force more pharmacy deserts. So that's pretty significant. It actually has legal repercussions for the CEOs for doing this. So for the first time in a long time, people can go to jail. Now, that to me is significant because when you're sitting across the table from Bill and Shannon Schmitnick, and their 22-year-old son lost his life because of the manipulation of an asthma inhaler, made it unaffordable, party goes, this is wrong, somebody belongs in jail for making that decision. It's one thing to try to make a buck. It's another thing to make extreme levels that people give up their lives. To me, if anywhere else, we call it death by formulary. Okay, so how isn't that a form of murder? You made that life-saving drug unaffordable on purpose for your financial benefit. How is there not some type of legal repercussion there? So HR 96 is intended to have some of those type of teeth. So I kind of went on both ends of the spectrum. It does other things, I'm going to say, that codifies good common sense. It says, you know what, you can't screw people on purpose anymore. So corporate salaries in America is a big hot topic, right? And I'm going to say that if you invented something if you invented something that changed people's lives, okay, I'm old enough that the portable computer was a big deal. No, whoever that would come into play. Now, who doesn't have Microsoft Windows, and how many different ways has that impacted people's lives? Because you created something that was life-changing. For folks who created that other people want and pay for willingly at a price there, to me, that's capitalism. That's what we aspire to as a country. You wanted to spark innovation. You wanted people who made a difference to be rewarded, right? What I see here isn't that. This is an intent to purposely manipulate and hurt others for the benefit of you. If your job is to take a $3 vial of insulin and turn it into $594 just because you can, okay, your shareholders said, okay, you made us buy a lot of money, so I'll pay you that gross amount. I get that. Is that what this is intended for? That I struggle with, right? If it was paying people a fair salary to do a public service or run a company that achieved on fair merits and free market type of principles, yes, this is not free market principles. This is a form of extortion and manipulation at the public detriment. So to me, this is why Teddy Roosevelt took on Standard Oil 100 years ago. It was proved that the Rockefeller family basically owned all oil. So it's pretty predictable that could hold the country hostage. So between Teddy Roosevelt and the Sherman Act, that was put in place to be able to create fair competition because it was for the greater public good versus one person. Okay? Now it is ironically that Rockefeller then got angry, and he's the one who basically was a modern day inventor of pharmaceuticals because he found a way to take oil and turn that into a pharmaceutical and then invest into the curriculums of medical colleges to actually push the pill over there. So it's very ironic how that kind of intertwined in this story. But it's like, okay, if you don't learn from history, you're doomed to repeat it. Thank God we had a Teddy Roosevelt back then to avert the monopolistic implications. But now, 100 and some years later, let Lena Khan finish her job. Can we make sure that healthcare, we want to trust healthcare. When you look at the rest of the modern countries around the world and you see zero bankruptcies in 15 different European countries because healthcare you shouldn't go bankrupt for. And in our country, we have it be 60% of all bankruptcies. And we have fantastic facilities, and we have the knowledge. We have great people. You know something's just broken. Shared destinies is a concept that it means that we're kind of aligned together, right? If you come up with a car, you need gas. So gas and cars maybe have a shared destiny because you need each other for it to go. Well, here's a case where PBMs, pharma and health plans, and insurance brokers all have shared destinies. The bigger the rebate the PBM can get from pharma gets to be in the formulary to make sure they get to sell an awful lot of stuff. Because if they get 1/3, think about this, the United States is a huge market. And any business that can get 1/3 of the U.S. market is, oh my God, we are doing extremely well. Usually to get to 1/3 of a market, you need an army of salesmen going up and down the road, talking to doctors and pharmacists, etc., saying, my pill is better than my competitor's pill. They don't have to do that anymore. To be able to sell 1/3 of America, they got to say, hey, one of you 3 PBMs, can I get on your formulary? What's to get in your formulary? Well, you got to have science at least that can work to some extent, right? But then the rest is all about cash. And now, who ends up paying for that? Of course, the rest of us. So shared destinies is pharma and PBM certainly have a shared destiny. Then pharma and health plans, because if health plans make more money, the more things cost, and PBMs get to drive up the cost, there's a shared destiny there because the more PBMs win, the more the health plan wins. Then finally, insurance brokers, if you're able to peddle the plans that include these two, you get a bigger commission. So they're all shared destinies. The more the insurance broker sells of one of the big 3 plans, the more money he makes, because we'll see some of these incentive plans. Hey, Mary, instead of you selling 10 plans to 10 different companies, how about you sell my plan to all 10? Because if you do that, your commission just went up tenfold. So you are financially driven there. So share destiny that you want to do that.
And so how do you think test, teach, therapy, test can put an end to those shared destinies?
Test, teach, therapy, test is more of the grassroots level to help pharmacies and patients take care of themselves so we don't have to be beholden to insurance companies or health plans. Because we think whatever the insurance tells us that we should do that's good for us. The answer is that is absolute nonsense. Who's the person that most people trust the most? The person that look in the mirror every day. So we have to give them basics. Healthcare is awful hard to learn, right? So you're not, nor should you ever teach them to be doctors, but we liken it to like most of us take care of our vehicles better than we do our bodies, right? Even if we don't change our own oil, we go to our oil change place or Jiffy Lube or our mechanic and says, okay, I need my 3-month checkup. Check the oil, air in the tires, fuel filter, oil filter, etc. Make sure this goes. I don't want to blow my engine. Even if we don't do it, we know we need to do it. We go do it because we can't afford to blow our engine. So we do that for our cars, and most businesses do it for whatever their asset is. Do I own equipment, etc. So for most of our society, we take that as just the right thing to do. And here we are, the most valuable asset we have, ourselves. We don't do the same common sense. So test, teach, therapy, test is, we know that our bodies, certain things. Can we test our vitamin D level? Can we test some of our cognitive functions? And other things that matter the most. Now, most of us think, well, we can only do that at a hospital facility. That's not true. There's things now, and most of the rest of the world, actually you go into a local pharmacy, they have all kinds of test kits there for you to be able to check your oil. And you know what? Most of our core things that happen to us is because we don't have basic levels of nutrition, sleep, stress management, and move, right? All 4 of those, we can learn the basics on our own and do a test, teach, therapy test that says, okay, do I have enough vitamin D, which we equate to oil in our body? What the heck is vitamin D? Most of us won't know. I didn't know until 7 years ago. Then after I learned this, I'm going, this is something we should learn back in 5th grade. And this is something the rest of the world will actually do once, twice a year. Where am I? Vitamin D, right? So the test, teach, therapy test is to help people saying a true health plan or strategy is one that you have that prevents the disease that none of us want. Right now we wait until we feel so sick, and then we don't want to go to the doctor because we don't want them to tell us bad news. But ironically, then we keep the same behavior until we get the bad news. We don't need to go there anymore. So between the test, teach, therapy test and your local pharmacist, we can do, I'm going to call the easy stuff. We're the ones that don't want you to have these bad outcomes. And also, we love our local docs, and we can actually help you. This is beyond what we can do. It's time to go see a doc. And by the way, here's the one that will trust you. Here's the one that may or may not be part of the system to do so. And by the way, free market, these things are much more affordable than you think. And so we want to give people alternatives and solutions to what we can actually do to help. We've learned an awful lot. And it's like, man, this is something people ought to know. And, we've contemplated if folks like this kind of style, we can bring together experts to be able to do a how-to to help you teach, test, teach, therapy, test, to be able to take care of yourself. And then when do you access the right personal healthcare system that will help you? There are some fantastic foundational doctors, etc. And before this sounds like it's snake oil, just the opposite. We are literally teaching you how to block and tackle. And it's one of those things where if I'd have known this 30 years ago, I would have prayed to teach me this kind of stuff. So test, teach, therapy, test is one other method that independent pharmacists can help you. And then here's one point to really consider. We've all heard about drug interactions or side effects, right? As we see those commercials on TV that says, hey, the side effect might be all these big scary things. Ironically, nobody ever talks about the most common side effect that exists at almost every single thing you take, which is drug-induced nutrient depletion. What is drug-induced nutrient depletion? Well, guys, I think almost everybody, we've heard about this, for reaction is a reaction. So we put something in our body to do something. It's meant to be something good, right? So this is nothing negative against the drug you're taking. But what they don't tell us is with everything we do, it does something else in our body. And it might actually deplete something else we need. And every single drug has to state with the FDA that if I did this, it depletes something. It depletes vitamin D, and depletes a B vitamin, it depletes CoQ10, etc. And we believe it's one of those basic things everybody should ask. Hey, if I'm taking this drug, is it depleting anything? Because what we find out is many times this drug does a good thing, it depletes, and all of a sudden, we had to prescribe a second drug because we got to solve for this depletion. That depletes more, I have to get a third, fourth, fifth. So many people watching this, I start out with 1, but now I'm on 6, 7, 8. Well, ironically, some of that might have been averted by, we took this one, it did what it was supposed to do, and by being depleted, how do you solve it? It might be you need to eat more or something, right? Food is always the best medicine. Well, if you can't eat enough, then here's a supplement to simply shore that up. And if your body has what it needs, you heal, you don't need any more. If it depletes and it takes away from something else, pretty soon something else goes awry. So us, to believe the most fundamental thing that we hope everybody learns from this is, please ask, is there any drug-induced nutrient depletion with this medicine? I just want to know, because if it is, maybe I choose to do something about it. Most people, pharmacy has changed so much in the last 30, 40 years, and the vast majority of our folks are accustomed to either mail order or I'm going to call it some of the chains. Ironically, 30 years ago, I worked as a cook in a store that actually got bought by one of the more famous chains. And this particular company had a stellar reputation for 90 years. It was run by a family who really had excellent core values and ethics, and they are one of the name brand names that you are familiar with. So all the way up until the late 90s, they really did a great job. Then Wall Street occurred, and now pharmacy the last 10 years has changed dramatically. I really had my hats go off to pharmacists, those chains, because they have a really, really tough job. An independent pharmacy, we've always felt it's much safer, and the right customer service is for every 200 prescriptions having one pharmacist, 2 or 3 techs, because then you can actually check and consult and actually deliver care with every prescription. Some of these poor folks at the chains, they might have one pharmacist or one technician trying to do 800. So it's humanly impossible to deliver care with all 800, much less answer questions. So the question we have for you is, what's your experience been like? Does your pharmacist have any time to actually spend with you to get to learn and know you? Or is it simply you have any questions? If not, then please move on, because we got a whole line behind you. It breaks our heart because we've seen pharmacy where it was and where it should be, which is really the entry point to healthcare, right? We are the easiest access point. You don't need an appointment. You can show up and say, I'm just not feeling well, right? And that's where you say, okay, is it a cough medicine? Is something else? Go see a doctor, or whatever the right advice is. So we just felt that healthcare started with a local access point, of which there's usually more pharmacies. So we relish in that function. So for folks who've never experienced independent pharmacy, that might be a foreign concept. But I want to share with you that part is real, and probably what we hope folks aspire to again. Because healthcare shouldn't be waiting 6 months to get in to see a doctor for 5 minutes. Healthcare should be somewhere where you can actually have an interaction. Yes, you can search online, get it all kind of prepped up, but there's a reason why folks get 5, 6, 7 degrees is to be able to ask questions to help you get to the right answer faster and be accessible. So independent pharmacies have so much to offer that most folks don't realize. So educate, enrage, and engage is what we're really aspiring to. As we had this unique experience the last 20 years of going through these things, of having to learn about health plans and design and insurance brokers and PBMs and so forth. It's like, wow, I wish I'd have known that 20 years ago. And then how many people would want to know this? So I'm happy to say that in Fort Riley, Wisconsin, at the local cafe, I probably had a similar conversation to this literally no fewer than a couple hundred times. I was always pleasantly surprised that folks kept asking for more. We know something's not right. We didn't know this. We didn't know that. We need more people to know this. So educate is by far our number one goal here. Is if people know what's happening, they can make their own choices. Enrage. There hasn't been too many people yet when they learn that a young man died because he couldn't afford insulin. Another young man died because he couldn't afford his asthma inhaler. And each one of those should have cost $30, $40. Instead, they cost hundreds and made it unaffordable. People died. That enrages an awful lot of folks. Then finally, engage. If every 100 people watches, even one or two says, okay, I've had enough. I'm going to call my local legislator and says, okay, we need to have PBM reform. We need to fix this because it affects all of us. That will make this extra special. Because if there is an army of folks that are going to both the local and federal legislature says, we've had enough, we need to fix this, we're becoming more educated, you can't lie to us anymore, we see through your lies. In each one of these categories, there are good PBMs who are transparent, who want to do the right thing. There's just not a level playing field. Once people know what's happening, there's a level playing field, you will see fair competition that goes back to you've got to take care of folks, right? And happily, we're already seeing that occur. We want to have it faster. Same thing with the health plan. Yes, we need hot doctors in hospitals, for God's sake, yes. And they have to be able to be economically viable. But you don't need to pay $60,000 for surgery that you can pay $8,000 for. MRIs. We know that you can go almost the same facility, and if you pay cash for it, it's $400. If you pay through your insurance, it's $4,000. Why? That's what kind of happens when you start going through health plans. Back to they get to make 20% of $4,000 versus $400. They don't like that. Employers. You're about to learn from our class action attorney here that you have significantly more risk. Because for the last 10 years, all these bad things have happened because who was the fiduciary? Who was supposed to take care of people? Well, it turns out the only one was you, employers. There was plausible deniability, meaning you didn't know what was going on. But you'll find out that there's actually laws in the past that isn't going to be good enough anymore, that you have the right now to ask the broker how you're making your money. And if you're okay with the broker making more in a prescription local pharmacy, that's going to be your choice. But it's also going to say your employees, who can sue you soon, that they might not like that. We hope that 3 sticks and a carrot become part of the American vernacular. The 3 sticks are, soon you have a chance to be sued by your employee, by the Department of Labor, or by your shareholders. If you selected the wrong vendors and they are taking advantage of your employees and overcharging you and them and contributing to bankruptcy, that's going to be on you. The good news and the carrot is, if you select the right vendors that are actually aligned, you're probably going to save, there's already evidence, you'll save between 10 and 50%, an average of 30%. So you literally can do the right thing and protect yourself and save 30%. If you ignore it, keep doing the same thing, now there's going to be more repercussions. So back to educate, enrage, and engage. Employers, you have more work to do, but it's worth it. Eliminate risk, get lower cost, help your employees. Employees, you have hope. You have the right to ask these questions. Who is our PBM? How are they charging us? Who is our broker? How are they charging us? And if your employer is continuing to making some bad decisions, you're going to have recourse. Back to engage. We can all make a difference. So calling legislators, state or federal, and your employer can all make a difference.
If this conversation stayed with you, you're not alone. The stories you're hearing aren't rare. They're happening every day, often quietly, often unseen. And the more we understand the system, the harder it becomes to ignore it. If you want to support this work, you can contribute to our mission so we can continue to produce educational content through the link in our show notes, or simply share this episode with someone who needs to hear it. Start a conversation, ask questions, push for transparency, because change doesn't happen in silence. You can find the full Modern Medical Mafia Docuseries and additional resources online and in our show notes. And follow along as we continue releasing more conversations that expose how the system really works. Until next time, stay informed, stay curious, and don't stop asking who's really in control of your healthcare. See you next time on the Modern Medical Mafia podcast.